Our next speaker is a dear medical oncology colleague of mine, Dr. Thach-Giao Truong. So Dr. Truong is a nationally known melanoma expert and the director of the melanoma program at Cleveland Clinic. She finished her residency at Columbia University and her fellowship at UCSF, and then was tapped to lead Kaiser Permanente's melanoma program nationally. She led the board of directors of the Association of Northern California Oncologists before moving to Cleveland Clinic to head their melanoma program. Dr. Truong will be speaking with us on supportive care and melanoma after treatment. Thank you, Dr. Truong, for joining us.
Thanks for that kind introduction, Ray. It's wonderful to be back here with our Kaiser Permanente community. Really nice to see everyone. Let me share my slide. I will be discussing supportive care after treatment. And I love that I'm following Drs. Mansfield and Siegel in talking about what to expect in survivorship. Because it is very true that first and foremost, you want to thrive as a person. And many of the things that was brought up so far really apply at large. You know, how do you speak about the things that are important in your life? How can you thrive and live well every day? I will be speaking a little bit about some of the technical aspects that can come with treatment, but ultimately, you know, it's you as the whole person who will be who we care about and who we want to do well. So this is just one part. So what all is part of melanoma treatment? So one part can be surgery. That applies to early stage melanomas where the tumor is contained. And you can see here, you know, that can be on your skin, can be a fairly large surgery or more limited. It can also involve lymph node evaluations. So to the left, you see a lymph node biopsy, or some of you have undergone more extensive lymph node dissections, meaning where they take the whole basin of your lymph nodes because there's concern that there's more advanced melanoma. It's a practice that's gone away, but for some, this is still at this time recommended. So can be, you know, a significantly invasive part of your journey. Radiation can be a part of your journey. If you have bulky lymph nodes, this may be recommended after surgery. If you have melanoma in multiple sites of your body and some of them are causing pain, you might be recommended radiation. Or if you have it in the brain, it can be also radiation there. It can be in parts of your body that are more sensitive. So people with mucosal melanomas can be in your anal or vaginal areas. So, you know, you can see here, it's high energy radiation delivered to a certain site. And it literally is a treatment by burning of tumor away. And then, of course, there's drug therapy, which is what I do. I'm a medical oncologist. The two main treatment classes that are part of standard therapy, either after surgery to reduce your risk of recurrence, or as frontline therapy or early therapy for advanced spread melanoma, immunotherapy and targeted therapy, specifically targeting the mutation that's driving melanoma, BRAF/MEK. Two landmark achievements that were driven in melanoma, and immunotherapy really, while started and discovered in melanoma, have really changed the landscape of cancer care and now resulted in half of patients with melanoma living beyond 5 years who have spread melanoma. We have 10-year data now to show that people who've made it to 5 years, you know, go on and do just as well 5 years later at 10 years. And that is just remarkable. These are some of the drugs that you might have heard about or seen or received. Yervoy was the first immunotherapy to be approved. It's an anti-CTLA-4 agent. There's Keytruda, pembrolizumab, nivolumab, Opdivo. And then most recently, the latest checkpoint inhibitor immunotherapy approved is relatlimab in a combination called Opdualag. You can also give targeted therapy and immunotherapy together. That's not as commonly done, but there is a triplet combination approved, atezolizumab, vemurafenib, and cobimetinib, the brand name Tecentriq, Zelboraf, and Cotellic. And then many of you may also be offered the combination of ipilimumab and nivolumab. So many different ways to receive these very effective drug agents that have led to such amazing survival and improved survivorship and long-term stage 4 survivors, a term invented and coined in melanoma thanks to these amazing treatments. The combinations for targeted therapy you see here, some of you may have seen them. They can be given after surgery or for spread disease here as well. Dabrafenib, trametinib, vemurafenib, cobimetinib, or encorafenib, binimetinib. So what are some of the complications from these treatments? And what can we do to help them? You see here, lymphedema can be one from surgery and the lymph node surgery to the left. And then you see some of the side effects of radiation to the right for someone who had sort of a head and neck tumor. So one important part is skincare. It can be after surgery because you want your wounds to heal well. Here, an important part is to keep everything very moist so it can continue to heal and come back together. And this is courtesy of my surgical colleagues here. Aquaphor or Vaseline is key. Keep everything very moist. Don't let it dry. And keep the wound clean. Avoid contact with water, even massaging some areas, that for those of you who might tend to keloid or have contractions can help have the best functional and cosmetic outcome after surgery. And of course, sunscreen. It's a very sensitive new skin healing area. And, if there's sun damage, you can have discoloration later. And so covering the area up or using SPF is very important. You can also have issues after radiation. And even some of the drug therapies you'll see later can have drug rashes. And so one important part of having skin heal when there's either radiation damage or an itchy rash because of either immunotherapy or targeted therapy is creams and ointments, steroids specifically. You can see from the prior radiation rash, because it's so open and burned that sometimes, it's an easy area that can get infected. And so use antibiotics there. For more deeper burns, it's silicone foam bandages. Less clear whether they help, but I know many colleagues in radiation oncology use it as topical therapies like aloe vera, hyaluronic acid, if it's gotten very tough and fibrosed, silver sulfadiazine, which is similar to just treating it like a wound, and then silver nylon dressings. So, basically the strategy being that you try to calm down the inflammation and treat similar to the radiation, to the burn that it really is. How about lymphedema? We talk about that a lot. I mean, obviously, one way to manage it is to have a very thoughtful discussion with your surgeon whether you want such an extensive surgery. And I mean, there are many studies now that are trying to decrease the need to have to do such an extensive surgery where you might have swelling of a limb subsequently. The overall goal, once you have it, is basically to limit the progression of lymphedema. And that's a very important point. Many people at the beginning, are very active in sort of going with the plan to reduce the lymphedema, but don't realize that it's really an ongoing effort. And it's multimodal. They call it a complete decongestive therapy. So you're really trying to get the fluid out. You want to reduce the limb volume that's swollen from fluid not being sort of sucked back into the vessels because the lymph nodes are gone. And of course, you want to improve comfort. because it can be very uncomfortable to have something so swollen. You want to be able to have better range of motion, by decreasing the swelling, and overall just better quality of life. The first phase is very active in the first 2 to 4 weeks, and some of you may have friends or family members who experience these symptoms from breast cancer surgery or other type of surgeries and down in the groin that may take out lymph nodes. You want to make sure that you take care of your skin and nails well, because infection can drive a lot of swelling as well, so you don't want that. You'll be connected with a physical therapist who will teach you therapeutic exercises. They can also do manual massage and lymphatic drainage to get the fluid physically out. And they might teach you or your family members on how to do it for you. And then they do limb compression. So physically, you will be wearing very tight bandaging for 5 days a week to sort of reduce that. And so you can see already from what I'm describing is, you want as much as you can to not have it get to a point where it's too much. And then the second phase is indeed maintenance. And that is a very important part. You'll notice people recommending you compression garments or self-compression bandaging, especially if you go into airspace where the air pressure may be different. They want to sort of conserve and optimize everything that you achieved in the initial treatment phase of those 2 4 weeks. Sometimes, there's relapses and then you can go back and restart with physical therapy, but you really, the earlier you intervene and maintain, the better you'll do long term. And so these exercises that you're taught in the first 2 to 4 weeks, you really want to keep doing those. And some people are quite good at doing their own manual lymphatic drainage. From drug therapy, I think the most well-known now side effects that might be long-term for someone who lives a long time are those related to immunotherapy. I always say, nothing's for free. If a treatment can give you ongoing control of your tumor because it's activating immune cells against your cancer, well, unfortunately, those same immune cells can also end up attacking you, and some of those side effects could potentially be long-term. It's not very common. We're talking about a risk of less than really 10% that are really long-term and debilitating, if that. But I think the concept that really anything in your body could stand to potentially be attacked by these immune cells that are activated by your treatment is important. And I like the schema because you can see really literally every organ, either hormonal, neurologic, in the eye, in the lung, in the gastrointestine, can potentially be inflamed. And they manifest very differently. Here you can see a rash, redness of the eye. And so really when you are going through treatment or even up to a year later, be prepared that this may occur. We talk about, and it can really affect any organ type. It can be mild to severe, short-term, and then resolve. And when you stop treatment, like I said, in some people, it can be severe enough that it's long-term. And can continue then after you stop treatment even, and as you know, immunotherapy, even for its effect on cancer, will, once your immune cells are activated, will continue to do so even after stopping treatment. We all in the field always say our most famous patient with melanoma is President Carter, who just recently this year celebrated his 100th birthday. It just recently shared the details of his treatment course, and he only got 6 months of treatment. And that was 9 years ago, when he was 91. So, it's very powerful. And these effects are not dose related. So there's still a lot of research to be done. Obviously we're very thrilled to get the anti-cancer effect, but how can we better live with some of the immune side effects that occur? This is sort of to a schema for you to get an idea of what to expect in terms of when throughout your course, because it'll be something that you're going to be communicating with your treatment team. And so the most common side effects occur relatively early, and those are sort of itching, skin-related things. You'll see the things related to the gastrointestinal tract, like diarrhea, occur early, but then go away. So if you don't get it in the first 3 months or so, it becomes less and less likely that you will. The hormonal side effects, on the other hand, you see the green curve here, peak much later. So they tend to be later side effects. They're much less subtle. They're not unlikely for you to be going to the hospital for, but they're there. And then again, the liver and lung side effects here are early. The general approach here is that you want to just monitor your symptoms closely, especially in the first few months of treatment, where severe side effects that might end up in the hospital can occur. And you want to work with your oncologist and their whole team to communicate any new changes pretty quickly, so that they can intervene early. That's really key. An immune side effect, can really evolve quickly from one day to the next, because it's just a full immune activation, similar to, let's say, a peanut allergy. It doesn't really wait around. It's either going to have a full-blown one, or you're not going to have one. And so, it's not something that you want to sit on and wait. As the symptoms become more severe, your oncologist actually may reach out to some of their subspecialty colleagues to help work with you to calm down your immune system, because depending on your organ type, it can really be very different. And this is sort of the schema here for you to see. Grade 1 down here is a very mild side effect and may not mean anything. Grade 2, grade 3, grade 4. So it just gets more and more severe. And as it gets more severe, the treatments are considered to calm down your side effects will escalate. And so there's steroids that you take by mouth, and then if you're hospitalized, it's very common that other specialists will get involved. This is something we do here at the Cleveland Clinic and many other centers. And at Kaiser Permanente, there's actually also a system of specialists who have a specific interest in immune-related side effects. They're scattered sort of throughout Northern California. You can see here they can come from multiple specialties. So if you have joint aches related to immunotherapy, you might see a rheumatologist. If you have lung inflammation, you'll see a pulmonologist. If you have hormonal side effect, it'll be an endocrinologist. And they need to. It's important that they know that you are someone who's had cancer, who got immunotherapy, because the same strategies to calm down your immune system if you didn't have cancer are going to be different, because obviously you just worked so hard to activate your immune system to get a long-term response against your cancer. Just tamping it down, carte blanche, you don't want to do that. So you want to work with the whole entire team to find just the right balance for you that's okay for you. And of course, I have to highlight AIM's resources here. There's this AIM with immunotherapy website, and it's just wonderful resources to understand those side effects better and how to manage them. And I actually love that about immunotherapy. It's a really very collaborative process as you go through treatment between you and your physician and your treatment team. And these are really great resources for you, and I highly encourage you to go look at them. And some of those may be relevant even after you start treatment. Excuse me. So the other class of agents are the targeted therapy side effects, meaning they target a specific mutation rather than your immune system. And here, the side effects come from your body the drug reacting to other things in your body that looks similar to this BRAF/MEK target. And so esoteric side effects can be a fever, sometimes quite high, up to 103, 105. Joint aches, can have abnormal organ function like liver or kidneys. Can also have a rash. It can be actually quite similar to an immunotherapy rash. If you just look at it, it can be itchy. It can look like acne. Diarrhea can also feel similar. It's quite watery, many bowel movement, nausea. The other things that are more esoteric to it and specific to it is there's a paradoxical development of non-melanoma skin cancers, although by doing the combination treatment with a MEK inhibitor, that's significantly reduced, but that's another reason why it's important to stay in contact with your dermatologist. And then in a very small group of people, it can reduce your heart function, which is why, those of you who've been offered this treatment are asked to do a heart ultrasound. Now, the key to this treatment class, as opposed to immunotherapy, is if you reduce the dose or you stop the drug, the side effect goes away. And so I'm not going to talk about long-term management here. This is really more just knowing that the side effects are there, and and that they're dose related, meaning if you reduce the dose, you are going to feel better. If you hold the treatment, the side effects usually go away in a few days. So that's a very key difference. So it's usually not long term. If you are on treatment long term because you have spread melanoma and you really need to stay on treatment, your treatment team will connect you again with specialists or different treatments so that you tolerate the treatment better. And it's going to be sort of a balance between what dose you take and what supportive strategies you use. What else can change with treatment? What can we do? And so, we saw that really any part of your body can be involved in treatment between surgery, radiation, and drug therapy. And so some people experience cognitive changes, maybe because they got brain radiation, or maybe just because of where the location of their tumor is, if they have brain metastases. They can still be cured long-term, like President Carter, because their immune system can reach the brain. 50% of patients actually get a response in their brain. However, the initial damage from having something there can lead to cognitive changes. Anyone with cancer, and I love Dr. Siegel's initial talk, it's a really emotional journey. And until you really know whether you're okay, there's a lot of uncertainty. And so anxiety and depression are common. They're not direct side effects of your treatment, but this is what you might be experiencing as you go through it. And actually, I've had some patients where this is actually harder once you finish treatment, because then you just aren't as busy and you can really sit and think about all the different impacts that have been on you. And so you want support for that. Your physical fitness may change, depending on where your tumor was or what your recovery was like after surgery, or maybe even after radiation, depending on which part of your body received this burning treatment. And your healthcare maintenance may change. You can see for hormonal changes, you could have diabetes or other things, and your sexual health, and so of course pain management, depending on where your tumor was or how your surgery went and recovery. But there's actually solutions to all of it. So, we want all of you to do very well and be at your best. And so there's strategies like memory training, organizational aids, occupational therapy, speech therapy. There's a lot of tools to help you function better, no matter where along your journey you are. I always bring up psychotherapy and behavioral oncologists, and behavioral oncology psychologists and psychiatrists are now available, and I love that there's been specific attention brought to this area, because it's a different. You have a reason why you're feeling these things, and that reason will be with you. And so it's great that people are acknowledging that this is a real impact on anyone's mental health. I love Femi Mansfield's discussion of exercise. Hopefully that and a good diet will be, that's really something all of us should be doing. Sometimes you need a little extra help. I saw one of the questions was, well, I'm on steroids, I really gained a lot of weight. And so sometimes you need a little more. And so please reach out to your providers. There's medical weight management courses. There's other weight loss help now. So definitely don't think that anything of that is expected. We want you to come back to your baseline or better as much as possible. You do always need insurance. So good access to preventive medicine is very important. If you're going to live and be a long-term 10-year survivor and longer for melanoma, guess what? You go back to the pool of all regular people, which means we want to have you have all your medical issues be best managed as possible, your preventive screenings, all your labs. And so nothing's for free. And there can be urologic and gynecologic specialists to help if there's complications in your in terms of sexual health or urologic function following melanoma treatment. I love support groups, and AIM has many. They can actually address all of this together. And so the take-home message here is really any treatment for any cancer, but especially melanoma, which is multimodal, can have side effects, and they can be long or short. You want to talk to your treatment team throughout your journey because there's many tools to help at every stage of survivorship. So don't think because you're done with treatment that there's no help or no one thinking of you. And you may end up seeing more team members beyond your immediate treatment team. So just let everyone know what your concern is, and they can connect you to the right resources. Ultimately, living and thriving with melanoma is living well in all aspects of your life. Okay, I think that's really a key message here. So please share questions through the chat, and I'll give the microphone back to Dr. Luke.
Thank you, Dr. Truong, for helping us understand the science of melanoma and supportive care, and for being one of the leading oncologists in the country, helping us move forward in the field.